I'm speaking. Thank you. Abigail Marshall Ketting is my name, and I am the chair for Adult Health and Active Lifestyle Scrutiny Board. It's good to see you all. Today's meeting is being webcast on the council's website so that any interested members of the public or other stakeholders who are unable to observe in person can still observe remotely. This meeting recording will also be available on the council's website after today's meeting. I will now invite board members to introduce themselves, and please could you kindly mute your microphone once you have introduced yourself, starting with you, Councillor Iqbal.
Mohammed Iqbal for Hunsleton Riverside Ward.
Good afternoon, John Beale. I chair Health Watch Leeds and I'm a cooperative member of this board.
Luke Farley, Labour Councillor for Bermondsey and Richmond Hill.
Good afternoon, Councillor Eleanor Thompson, Guiseley Rawdon Ward.
Good afternoon, Councillor Sharon Burke from Middleton Park Ward.
Good afternoon, Councillor James Gibson, Crossgates and Winmore Ward.
Good afternoon, Councillor Taylor from Chapel Allerton Ward.
Councillor Kidger. Councillor Kidger.
Hello, Councillor Wyn Kidger, representing Morley South. Sorry.
Councillor Conrad Hartbrook, representing Rothwell.
Good afternoon, everyone. I'm Councillor Caroline Anderson. I represent Adlan Wharfdale Ward.
And good afternoon, Norma Harrington, Weatherby Ward.
Thank you. Could I ask supporting officers to please introduce themselves, please?
Good afternoon. My name's Richard Jones. Oh, sorry. Yeah.
Sorry, Richard, it's myself and
oh, sorry, apologies.
Council supporting officers. That's all right. I know you're keen, so we're really pleased to have you, but you will be observed.
Good afternoon, everybody. I'm Angela Brogden, Principal Scrutiny Advisor.
Good afternoon, Toby Russell, Clerk to the Board.
Thank you very much, board members. Okay. Before we move into our formal meeting and agenda now, I would like to take this opportunity to welcome Caroline Barrier to her first Scrutiny Board meeting as our Interim Director of Adults and Health. As the board is aware, Kath Ruff stepped down as Director earlier this month to take up a new role with the Council as the Project Manager for Social Care Transformation. I am sure board members will therefore want to join me in also paying tribute to Kath for her achievements as Director and also for the support she provided, especially to the work of Scrutiny over several years. Given her new role, I am sure we will continue to value Kath's contributions at future Scrutiny Board meetings. So we are now looking forward to working closely with Caroline and her team, and I would like to invite Caroline at this point to make any introductory comments to the board. Over to you, Caroline, and you're welcome.
Thank you very much. I'm really pleased to be here and will be attending all Scrutiny Boards going forward. I haven't been for a while, so it's really nice to be here, and thank you very much for your warm welcome.
You're most welcome, and thanks for joining us today. Okay, straight to our more formal meeting agenda now. I will ask Toby to go through items 1 to 5 for us, please.
Thank you, Chair. Under agenda item number 1, there are no appeals against the refusal of inspection of documents. Under agenda item number 2, there are no items which would exclude the press or the public. Under agenda item number 3, there are no formal late items of business. Under item number 4, can I ask members to declare any interests? And under agenda item number 5, no apologies have been received for today. Thank you, Chair.
Thank you, Toby. Please, could I ask that we approve the minutes as a correct record? And that meeting was the 17th of January. Dr. Bill, yeah, you want to come in.
Thank you, Chair. If I could just raise a brief point on item 54 on the minutes, which related to the meeting held on the 17th of January. And in those minutes, there was mention of obviously the meeting prior to that, when we discussed dental services. And NHS England, Emma Wilson was there from NHS England, who mentioned that there was currently being undertaken a review of community dental services And the minutes mentioned a number of recommendations that this board made about things that perhaps they ought to include in the review. It was alleged that the work had been finished and they were now acting on some of the recommendations. Because I was uncertain exactly about that, Angela wrote to Emma Wilson seeking clarification. I understand now that not only has the review not been finished, and they did start last summer, so it's been going on quite a while, that they don't intend to complete the review until this summer. I raise it now because I think we don't want to let it fall. This board expressed an interest in knowing what was in it. We made recommendations about things they might include. So I just don't want to lose it. I just want to say we need to pursue that when it is eventually published.
Thank you very much, Dr. Bill. And of course, you know, we do know that our dental services, which was the main reason why we brought them around the table, is very, very important to ourselves, and not just to this group alone. The other 5 districts as well have dental services on their agenda almost every meeting. Angela, could I bring you in here to kindly update us on any correspondence that has been sent through to ourselves regarding this agenda? Thank you.
Thank you, Chair. As Dr. Beale mentioned, I did seek further clarification, and that clarification sort of stated that the Community Dental Services Strategic Review work is ongoing, and it's actually the findings that they've reached so far that's subject to further stakeholder testing and engagement, but there is the intention for the findings to be published, and again the indicated sort of summer period this year. And as Dr. Beale mentioned, there was a commitment from this board that we would keep a watching brief in terms of NHS dentistry, and through the chair we also circulated a letter that the chair had wrote in her capacity as chair of West Yorkshire Joint Health Overview and Scrutiny Committee, because it's also on their radar as an area of priority. And this was to the Health and Social Care Parliamentary Select Committee, who launched its inquiry in December. So we're also eagerly waiting the findings of the national inquiry, which will also be reported back to this board for consideration. Thank you, Chair.
Thank you very much. Any other issues arising on this agenda? Okay, Angela, can I call you back in for matters arising on minute number 59 as well as 57, if you don't mind? Thanks.
Thank you, Chair. So 57 within the minutes relates to performance update. Members will recall that reference was actually made as part of this item to the Rob Borough Leeds Marathon, particularly reference to costs associated with taking part in the event, as it was felt that, you know, it could be deemed as a potential barrier for most disadvantaged groups and communities. So after liaising with the organiser on this matter, the Chief Officer of Operations and Active Leeds did provide the written response to board members as agreed. This was circulated last week, and within this it summarised some of the targeted engagement initiatives that are actually in place, just to give that further assurance to board members that community is at the heart of this event. In relation to minute number 59, it's the initial budget proposals for 23-24. Again, just to confirm, the board's deliberations on the relevant budget savings proposals did inform a composite report from Scrutiny. This was acknowledged by Executive Board during its meeting on the 8th of Feb, and it also forms part of the agenda papers for consideration at full council meeting tomorrow. Thank you, Chair.
Thank you very much. And I would also want to formally thank our Chief Operating Officer, Phil Evans, and of course the organisers of the Rob Borough Leeds Marathon on their consideration and concessions to this agenda item. So thank you very much from all of us on the board. Okay, so anything else, matters arising from January 17th? Board members, so do we accept that as a correct record of minutes? Excellent. Thank you very much. Right, moving to agenda item number 7, Leeds Safeguarding Adults Board Progress Update. So each year, the Scrutiny Board welcomes an opportunity to hear directly from the independent chair of the Leeds Safeguarding Adults Board. Within the agenda pack, members have been provided with a progress report in relation to the Safeguarding Adults Board, which draws upon its annual report for 2021 and 2022. Its progress against its strategic plan for 2022 and 2023, and some early thinking about its ambitions going forward. So I will now invite participants to kindly introduce themselves. And Richard, because Richard was so keen, Fiona, can we allow Richard introduce himself first? Right, over to you, Richard.
Well, thank you very much, Chair. And it's great to be back. My name's Richard Jones. I'm the independent chair of Leeds Safeguarding Adults Board, and it's good to be with you.
Good afternoon, everyone. I'm Councillor Fiona Venner. I'm the Executive Board Member for Children and Adult Social Care and Health Partnerships.
Councillor Arif.
Good afternoon, everybody. I'm Councillor Salma Arif. I'm the Executive Board Member for Public Health and Active Lifestyles.
Thanks for coming, Caroline.
Good afternoon again. I'm Caroline Barrier. I'm the Interim Director of Adults and Health.
Hello, everyone. Victoria Eaton, Director of Public Health.
Welcome.
Hello, everybody. I'm Shona McFarlane. I'm the Deputy Director for Adults and Health. Thank you.
You're all welcome. Thanks for coming. Right, Richard, back to you. I believe you've got presentation. Is that okay?
No, I haven't got anything. I'm sharing. I'm going to just introduce the reports. Is that okay?
That's fine.
Yeah. Okay. Well, it's, as I say, it's good to be back, and I think I was here last year and I think the year before too. So it's really good to have the opportunity to explore what the Safeguarding Adults Board in Leeds is doing, its challenges, and how it's working with its partners across the city. And that's not just the statutory partners, but importantly, third sector, voluntary sector organisations, community organisations too. So what I wanted to do very quickly, because you've got lots of paper in front of you, and I'm happy to speak to any of that. And it's fantastic. I've got three colleague board members with me. Councillor Venner sits on the board, Caroline sits on the board, and Shona does too. So between us, we will, I'm sure, be able to pick up and explore the issues you want to take forward this afternoon. So the document that's probably the most historic in here is our annual report for 21-22, but it's there for information. It's a statutory requirement of a safeguarding board to produce an annual plan and also an annual report. So we're bringing it here for your interest and scrutiny. Alongside that, you've got a report that just provides an update. It's the first report, but just provides an update of work that's happening at the moment. And alongside of that, you have the peer review that was undertaken by a team that came in nearly a year ago now to look at how well we were doing across our partnership in Leeds. So obviously happy to explore any of those issues with you. I think just a bit of context from me before I open it up to yourself and your colleagues. I think what we are seeing as a board, and I'm sure this isn't just a Leeds issue, and it's not just a safeguarding adults issue. I think we're moving from the kind of pandemic and ways of working that had to be established at that point to ensuring that we're working effectively together as we move beyond COVID-19. But we're doing that in the context, as you will all be completely aware as ward councillors, of significant challenges for individuals, for families and for communities. And particularly vulnerable and our most vulnerable citizens who will always potentially feel the impact of those issues most keenly. And it's in the context too, I think, of frontline staff and agencies really having to work flat out to manage demand that's rising, I think, both as a result of the cost of living crisis, as a result of mental health and well-being issues, as a result of the pressure that communities, families and community groups are struggling with. So what you see in the work that we're doing is we are seeing an increase in the level of concerns that are being raised about adult safeguarding. So there's a context to that, but I think that's a good thing. I don't think there's a position to which we would get where we'd think, do you know what? We've maxed out on the ability to enable people to speak up and have their voice heard in often very, very difficult circumstances. So we're seeing concerns rise, and in Leeds, they've risen 11% with the figures you have in front of you over that year of 21-22, and they continue to rise as we speak. That's against a national trend of an increase of about 8% and a picture of growth over the last 5, 6, 7 years. And as I say, don't think that's something to get concerned about. I think that's a real sign of people getting their heads around and understanding what adult safeguarding means and how and in what ways they can get support. What we've seen in Leeds, which is slightly different to the national picture, is that we haven't seen an increase in when those concerns are taken into an investigation, Section 42 inquiry. Those have remained broadly the same. And I think the Adults and Health are doing a whole range of things to ensure that they're making appropriate responses. Again, nationally, there's been a more significant increase, but we're kind of holding a line in Leeds. I think the other thing I'd just say about the figures is that increasingly it's issues around self-neglect or acts of omission that are at the heart of the kind of issues that individuals and families bring when they come to the attention of services. And that again is kind of reflective of a national position. I think the positive thing that I would want to report and underline is that when people engage with the safeguarding system, then 9 out of 10 people, they are either reporting directly or through a third party that the risks and the concerns and the worries that they had have either been reduced or eliminated as a result of the engagement they've had with social care services, health services and community services. I think the other thing I would just say quickly is that we continue to work with our 4 priorities. That is that we endeavour to be citizen-led, that we're led by people's real experience, and that it's that defines the quality and the type of interventions that we make. And we've continued to build our work with the Friends of the Board, with a reference group and with a whole range of listening events. Our second priority is one that we've got to continue to work on, which is to continue to improve awareness and understanding across all our communities. And I think one of the positive things we've done this year with the support of Voluntary Action Leeds is to engage with ethnically diverse communities, including for the first time the Chinese community in Leeds, to understand what it is that they're experiencing, the way in which they can access services and the sort of information they need to encourage people to come forward in often different cultural circumstances. And then the third priority for us is to continue to work with others at a citywide level, whether that be around collaboration with Safer Leeds or the Children's Partnership, but with a real focus this year on self-neglect and our work around how we support practitioners who have really complex situations to deal with, and the development of our exceptional risk forum, which Shona chairs for us on behalf of the partnership. And then our final priorities is ensuring that we continue to learn and enact and can demonstrate that we're making a difference, so that we undertake safeguarding adult reviews. I'm happy to talk about some of those, but more importantly, we can demonstrate that those reviews are leading to changes in practice, changes in approach, and the building of confidence in communities to come forward and share with us their concerns. And there's a whole range of work there around mental capacity, alcohol, fire safety, multi-agency working that I could talk about, but I'm not going to say too much more now. And then finally, Chair, just to say that we've been really well served as a board by people acting, board members acting as champions for key areas of work and taking ownership for key themes within our strategy. So I would want to thank our champions, but two other comments as well. Firstly, it's just to recognise that as we're having this meeting, frontline staff, whether they be in health, social care, in housing, in some of our community organisations, are dealing as we speak with complex and challenging circumstances, and we're only ever as good as the people who are there delivering our policies and procedures. And I think, as I said at the start, in the context of significant challenge and demand, we just need to recognise the work that's going on. Often as a board, you see things that haven't worked well, but actually I was in a conversation a week or two back with third sector colleagues, and it was a really mature conversation. And actually it was one that we wanted to have about what's not working well, but as much of the conversation was about recognising and valuing what is working well. And you've said something that I just wanted to say too, and it was really to say thank you to Kath for her contribution to the board and for her passionate leadership and challenge around the safeguarding agenda. It's always great as an independent person coming into a place like Leeds to have people who are serious about responding and wanting to move the agenda forward. So Kath has been a significant partner, and we'll miss her contribution to the board. I'll leave it there and open it up for questions.
Thank you very much, Richard, for that great presentation. And to just, I'll bring you in, Councillor Venner. Just to say thank you and lend our voice to the team. I mean, the report is very, very comprehensive. All of you will agree with me. And what I really liked about this report, apart from all the positives that you've put down for us to see, the challenges are also glaring, and you were not afraid to let us know what the challenges are. So obviously, before we finish on this agenda, I would really be interested in knowing the plans in place for the challenges that have been mentioned in this report. I'll now bring in Councillor Venner.
Yeah, thank you. I just wanted to add a couple of points. I sit on the board, as Richard referred to. I think it's very clear in the report that the Leeds Safeguarding Board has a very strong focus on citizens being at the heart of our work, and it's a particularly strong spread in the annual report, the hear me, hear my voice, hear my safeguarding story ethos. I have to say the partnership with Advonet is fantastic, and that's meant the voices of particularly people with learning disabilities has been really strong in our work. That's really important to everyone on the board, that people in minoritized communities, some of the most vulnerable people in the city, are supported through grassroots third sector organisations to be part of this work. And I hope that comes across strongly. As Richard said, we've done the specific work with people from diverse communities, and the listening event in December was fantastic when we heard really directly from people about their experiences of safeguarding. And again, that's been facilitated by small grassroots third sector organisations that we work in partnership with. Richard referred to the work around self-neglect. That's been a really strong theme because we've had some serious incidents, including deaths, that we've looked at where self-neglect has been a strong element. And we're really aware that the pandemic and lockdowns raised the risk around that, and particularly because people weren't necessarily going into other people's homes, and not necessarily care staff, because actually a feature of people who self-neglect is they're often people, who've got capacity and choose not to engage with services. But during the pandemic, you didn't have people like housing officers, people doing repairs, delivery drivers going over people's thresholds. So we've got a really great self-neglect strategy, and it's got people from across the council working on it, but also outside the council. It's a really strong partnership in terms of cross-council and partners. And it's got people on it like senior housing officers, because we know that for some people, the only people that will get across the threshold are housing officers doing the tenancy checks. But then it's equally important that MEAs, Liberty, who do our repairs, who do our gas safety checks, are aware of what to look out for. So that's felt like a very important piece of work involving lots of different organisations and different teams. And this report, the annual report, which is an appendix to this report, went to the exec board. So we've had a discussion at exec board recently around the safeguarding adults work. And you've also got our peer review. We had an LGA peer review. So it feels like the safeguarding adults work's in a robust place, although in a context of increased demand and increased risk that goes with that. Thank you.
Thank you very much, Councillor Venner. Yes, over to you, Councillor Gibson.
Thank you, and thank you for this report as well, and for all the good work you've been doing. That's clear in this report. I just wanted to ask you a quick question. In my experience, the sort of lower level safeguarding concerns, perhaps, you know, it doesn't even reach section 42, but even if it does, it's lower level. It's around neglect. It's around perhaps people that are cared for in a supported living or residential setting. The local authority and adult social services tend to be very well at dealing with those lower level safeguarding concerns, because we've got our hands on the levers of power to be able to do something, whether that's sort of revisit the care plan or work with parents or put in extra carers or whatever it might be. But where there tends to be a bit of a gap in my experience is when people perhaps have fluctuating capacity, or they do have capacity, but are certainly vulnerable in that they may have borderline learning disabilities or learning difficulties, and they're being targeted in a criminal way. So there's that element of criminality, and it's incumbent upon the police at that point to take responsibility and actually safeguard that adult. So adult social services will do everything that it can do, but if that adult is still taking part in risky behaviour but is a victim of crime, it's at that point where we as adult social services are sort of stuck, and it's incumbent on the police to do something, but often because of the resources or limited resources they have, they're unable to do so, as well as the issue of capacity and non-engagement. So I wondered if that situation's improved, and if your board's working with the police to be able to really target and focus in on those really vulnerable people that actually are perhaps are suffering more than you know, people that we traditionally think about when it comes to adult safeguarding.
Yeah. Thanks. Thank you, Councillor Gibson. Yeah, so and other colleagues might want to come in too, but the police are a key partner with us. We have Dan Wood, who's Superintendent for Neighbourhoods and Partnerships on the board, and they are absolutely tied into the shared approach and our policies and procedures. But I think you're right. I think we have to recognise that resources are stretched, and while I think policing numbers are coming back as part of the national strategy, possibly in Leeds, I'm not able to make too many comments about that, but so police numbers might be recovering a little bit, but the reality is, I think, is that people are stretched, and I think that's when you really have to get down to confidence of local working arrangements. So as you say, the reality should be that if somebody has got care and support needs that are unknown to the council, as you were highlighting, we should feel pretty confident that those needs will be monitored and people kept aware of. But I think the challenge we've got, and we're working with the police and other partners too, is how you keep frontline staff alive to and curious about, hang on a minute, what's happening here. So we know that people with limited capacity are probably at more risk of being targeted by other people in their neighbourhood or community. And that's where, as Councillor Venner suggested, we need people who are on the front line, if you like, not just police, housing officers, community workers, being alive to, hang on a minute, what might be happening here. So through the training we do, and through the overall kind of work of the board, we're absolutely wanting to ensure that we're not just there to pick people up when they've experienced significant safeguarding issues. And our self-neglect strategies, one of its key aims is around prevention. And I think it comes down to the quality of local working relationships, confidence between practitioners at the front in a community, and the ability and the willingness for people to pick the phone up and say, I've just got an issue here. How do I help? And I think that's one of the challenges that we're seeking to meet in the work we're doing with community organisations. It's how we build confidence and capacity in local organisations to feel, do you know what? We can probably manage this situation, but let's just have a quick check-in with the beat Bobby. Let's have a quick check-in with the mental health nurse who might be involved too. And it also requires people, and we've got work to do on this too, to feel confident about information sharing and to feel that actually they aren't hidebound by a set of rules that prevent us doing our best for an individual. So it's a long response to what I think is a real challenge that you're flagging. And I think we as a partnership, as a board, are wanting to and are seeking to encourage through training, development and learning about what works to ensure that those type of conversations happen and that we build or seek those relationships being built. So Shona, Caroline might want to say something about neighbourhood teams, and there's a whole range of building blocks where you're only really as good as the quality of the ability of frontline colleagues to talk to each other often.
Thank you very much. Yes, Councillor Venner.
Just wanted to respond to Councillor Gibson's point about capacity. We've had some really, really interesting conversations on the board about capacity, because I would say in some ways it's one of the biggest challenges that staff are working with, where I think where people have not ever got capacity, in some ways it's clearer, but where we've particularly been having these discussions is around, say, substance use, where people are sometimes capacitous and sometimes not. And these are some of the situations where people have refused intervention from other organisations and from support agencies and have the capacity to do so. So we've kind of identified really, and we've had some really fantastic support from academic colleagues who've undertaken some of our reviews around the Mental Capacity Act and the Mental Health Act and some of the limitations of those. So there's a real gap in the Mental Capacity Act around substance use, for example. You can't in law make someone go through a detox and rehab program. You just, that's not lawful. And I think when you've got people who are really have really complex needs and are leading quite chaotic lives, what you really need is time. Workers need loads of time to be able to spend with people and build up their trust. And that's one of the things that's been compromised as organisations have faced cuts. So that kind of assertive outreach that happens in the statutory world and in the third sector, that's a really well-researched approach to supporting people with really complex needs. And that's one of the real challenges that I think we face in safeguarding work is around issues of capacity. I do think the Exceptional Risk Forum that we've set up is a really good way of addressing that, though. That's a particular forum where people can discuss, from different agencies can get together and discuss the really complex cases. And that feels like a safeguard in relation to, people not just disappearing and falling between organisations because they're too difficult and they don't want to engage. So it's really challenging work, but it feels like we've got really good partnerships and structures to be able to address the challenges. Thank you.
Thank you very much, Councillor Venner. Have you got a follow-up question? Yeah.
So thanks for describing the work that you're doing to sort of work collaboratively with different professionals and organisations to identify safeguarding risks and pass it on. That's really important. I'm glad that you sort of acknowledge that and you're doing that. I'm glad as well that you're talking about issues of capacity, whether it's fluctuating capacity or whether it's somebody who has capacity in some areas and not other areas. But I guess the model that you're describing there is around engagement and reducing risk by taking the person out of the risky situation. So if the engagement with, say, somebody with substance misuse or somebody with moderate learning disabilities, engaging with them, even if if they are refusing to engage, and reducing risk by trying to take them out of the situation in that sort of way. But I'd like you to comment on is, in those situations, if they are the victims of crime, it is for the police at that point to take action against the criminals that are targeting them. So especially people with moderate learning disabilities or learning difficulties that are often targeted by criminals and are exploited financially or whatever it might be. And at that point, obviously, there is a question. It is difficult for the police, and I understand that it's difficult for the police, but they will often cite that there's a difficulty with regards to evidence and reliability of evidence, and it's difficult because they're refusing to engage with them. But it still stands that there is criminal people out there taking advantage of them, and it's for the police to take action. So what are we doing to try and improve that situation and try and encourage the police, if we are doing that, to actually take action against criminals that are targeting vulnerable people?
Yeah, okay, Councillor Gibbs. I can't answer all of that question because it's not for me to speak on behalf of a partner agency. And what I can say is that in relation to the learning that we've done, the reviews we've undertaken, the thematic work we've done, that hasn't been an issue. So it hasn't come to the board's attention through kind of our responsibilities to review what's not worked and what hasn't worked. So it sounds to me as though that there's a set of questions you might have as a scrutiny committee, or some scrutiny committee might have around Safer Leeds in relation to exploring whether you feel the police here in the Leeds district are doing what they need to be doing. But on behalf of the board, I'm not in a position, I'm afraid, to make any further comment on that. I'm not seeking to dodge it, but you're inviting me into a space that I'm not able to speak to. I think if there was learning from the work we've done that could answer the question, I'd be happy to share it, but there isn't. So I don't know if Shona wants to come in. Or do you, Shona? I was just looking down the table here.
No, I'm quite happy to come in. Councillor Gibson, you've described as I think you're well aware, some of the most challenging aspects of the work that we do in social work. And while I'm not saying everything's perfect, I came across a case last month where we had a gentleman who was being exploited financially by his neighbours. They were moving into his flat, they were taking his bank card, they were using his resources, and he was permitting that to happen because he perceived those individuals as friends. So, as you know, in Leeds, we've got safeguarding and risk managers who are senior social workers who are extremely skilled in this area. And the safeguarding and risk manager in that situation got alongside that individual, supported them to access the support the police were offering, and the police were then able to ensure that those individuals had no longer had access to his flat, and were forbidden legally from having any contact with him. So that worked very well. That built on what Richard was talking about in terms of the locality relationships that we have, knowing who's in the locality that you're working in, knowing your fellow professionals and working extremely well with them. So I think that's an example of when we know that it can work. I'm sure it doesn't work as perfectly like that all the time, but we do get the support in our neighbourhoods. So thank you.
Go on record that I still think you're doing a brilliant job. It's just, look, there's a gap there. I know, because I've been pulling my hair out for the past 7 years that I've been practicing social work, when I've worked with people with learning disabilities that fall through those gaps, and it needs highlighting. I mean, I wouldn't be doing the job if I didn't highlight it, but I do think you're all doing it, and I think Leeds does a fantastic job, in particular at safeguarding adults.
Thank you, Councillor Gibson. The only reason why I've allowed him go on because that's his lived experience every day. So I do know he knows what he's talking about. So thank you very much. I've got 3 people on this agenda and I would only take 3 because we need to move on to the next. So it's Dr. Bill first, Councillor Hatbrook, and then Councillor Taylor, and we'll move on to the next agenda. Thank you.
Thank you, Chair. 2, I hope, very quick questions. Looking at page 20 of the bundle, and Richard has made comments already about the increase over the past few years. Roughly over the 3 years, a 40% increase in the number of referrals. And of course, there are 2 possible reasons for that. One is the one which Richard has explained he believes to be the case, and that is that people are actually getting better at reporting when abuse takes place. The more negative one, of course, is that the number of abuses is increasing. So I just wondered whether he could say, what is there about his experience which says it's the former rather than the latter? And the other one relates to the proportion of safeguarding inquiries which are pursued at 25%. Well, that's 3,000 of those cases where there is a safeguarding inquiry, but that leaves another 9,000% where someone somewhere has expressed a concern. My question is, what happens to those? We've heard that some of them go to the police. There's comments on occasion, there are other forms of support, etc. They're outlined in the document, but there must be several thousand others where that's not covered. What happens to those?
Sorry, Richard, we're going to test you here. So you're going to take all the questions in one go and then answer them. So we'll see how you remember all of them. So Councillor Hatbrook and then Councillor Taylor, and then Richard, you can answer the 3 at the same time. Thank you.
Slightly concerned that my mid-taxing is quite mathematical. I was on to it's page 4 in your 21-22 report, or page 36 in the agenda, which is around the ratio between or changing numbers of referrals and inquiries. And I was just really struck by the numbers because they're quite big numbers. So taking the 2 extremes of dates, because the trend is the same. So between 2018 and 2022, we had a 40% increase in referrals. And I think you said there wasn't any significant change in inquiries, but actually there is. It's down by 12%. And I'm just wondering what's actually driven that, because I can't think of any other service where requests for help are going up, but actually we're doing less. Now, there could be a very amazing reason for it, because it could be that actually we're dealing with it in more creative ways, or we're filtering better, and the increase in reports could be because people feel more empowered and able to report. But obviously, there's something significant happened there that's driving those stats moving in those directions. And from the stats alone, you can't lift the bonnet up and see what's driving it.
Thank you. That's a very good question. Councillor Taylor.
Mine isn't a question as such. It was following from Councillor Gibbs. But first, can I say thank you, Richard, Shana, Kath that left, and you for the work, and Fiona for the work what you're doing, and adult social care. You're doing the best you can in Leeds and Leeds is standard. But mine is page 20, nature of concern, which is neglect, physical abuse, financial abuse. It's not a question, it's just a comment from similar, because some of these is happening indoors with families who neglect and abuse financial wise. And the individual are scared to speak out. That's from experience. That's what I think. Know from that they're scared of speaking out because they think their loved ones not going to be there to look after them, and so on and so on. But back to the police can only deal with what in front of them, and the police can't do as much as they would have liked to do without the evidence, because when they do go to question the individuals are saying, no, I'm fine, because the same abuser is sitting there in front of them and they are scared of saying what they would want to say. And this is where I applaud you for what you are doing, for the numbers, what's going up, is to identify, to put the right staff in there to see what's happening, because sometimes action does speak louder than words. And that's what I want to say really, and to say thank you and Sue and all the teams for what you're doing against AHAL. Thank you.
Thank you, Councillor Taylor. So you've got 2 questions to deal with. One was on your comment.
Thank you, Chair. And it might be that Shona wants to add in, because I think how the city manages the process of a concern through to referral is absolutely the work that Shona and her colleagues are involved in. But I'll just say something quickly. So I think Dr. Beale and Councillor Hartborough, you've asked in a sense the same question really, which is, you know, what's the balance between increased challenges for people and increased incidents, for instance, of domestic abuse and just better reporting? And I can't. We haven't got the sophistication around our figures to be able to take that away and look at that. I need to go away and see just how far we could get. But today I can't, well, I'm not able to sort of say, you know, 50% of that increase is driven by and 50%. So we'd have to do, it's a good question. We'd have to do some more work on it. And it could be we'd run into a brick wall at some point and not be able to answer the question. I think what we know and what we know nationally is that people are raising more concerns, and without a shadow of a doubt, we know, you'll know as ward councillors in your communities, there are increasing levels of mental stress, mental health issues, people's well-being is being significantly impacted. What we saw through the pandemic, as we locked up down and locked back open again, was real waves of increased demand as a result of people being sort of locked in together, and domestic abuse, say for Leeds, would have the same figures, went up and then would go down. So these aren't patterns of just linear kind of patterns. Things are going up and down, and we're giving you a figure here at a year end. Without a shadow of a doubt, my sense from working in the field is that the majority of those referral raising of concerns is as a result of people feeling more confident and aware that they can do it. So, for instance, we know that in some of our communities we are underrepresented in terms of the levels of referrals, but that's beginning to change. And so what we're doing is just giving people confidence that they can, through either a locally trusted organisation or through a statutory service, they can raise a concern and something will happen that doesn't leave them out of control. I can't give you the balance, but what we do know from looking at the statistics around demand for mental health services, for domestic abuse services, those are going up, and part of the reason for our increase here is for those going up. The reason that not all of them are then translated into an investigation is that, and I will bring Shona in, is that not all of them need an investigation, because actually the threshold's not met, or a different bit of support, a bit of advice, a bit of work with the individual, the family or the community organisation can result in the issue being better managed without the need to meet the threshold for an investigation. And the last thing we want is people going through processes that aren't needed for them. But I'm going to let Shona just say a little bit more about that, because I think what happens in Leeds is there's a set of opportunities to try and move people out of the safeguarding process when it's right to do so, and that is the case nationally too. We have seen a significant rise in concerns. There's not been quite that rise in Section 42 investigations, but that's because it's not just being let to happen. There's active management of that process. So I'm going to pass to Shona, if that's okay, Chair.
Thank you, Richard. The process is driven by the legislation. So there is a Section 42 inquiry process, which does exactly as Richard's just suggested. There's a no wrong door approach in Leeds. So if somebody does refer to us something that isn't meeting the threshold for safeguarding inquiry, it will get picked up in another way. So that could mean that we would undertake a social care assessment. It could mean that we would signpost. It might mean that we would spend a bit of time with somebody and help them with whatever difficulty it is that they're currently facing. So there's a number of different ways in which we might dispose of that referral, but it wouldn't be a non-response. So we do look at that occasionally and check that the response that we're giving is appropriate to the situation. We can examine by referral source the number of referrals that we get that don't result in any further safeguarding inquiry. Quite a lot of those sit with the ambulance service and the police. Both of whom have a fairly standard approach to making safeguarding referrals, which means that they quite often don't discern between in the way that another professional might. So there's a considerable amount of referrals from both sources that then become another type of inquiry, which could be a social care assessment. And then the third thing is just to reinforce what Richard said, which is the policy that we have is very citizen-led and very person-centred. And as long as the individual is happy with the support that we're giving them, we would allow them to guide our actions and get us to the place they need to be, rather than putting them through a process unnecessarily.
Thank you very much, Richard and Shauna. I believe Councillor Hatbrook, you've got a supplementary question.
Yeah, just briefly. I fully understand the referrals explanation, and because we all know that referrals did go up, during COVID, and actually people feeling more empowered to report things is to be celebrated. I'm not quite getting the inquiries, because it's such a profound change in that it's, we were doing 56% more referrals 4 years ago. Sorry, inquiries, not referrals, than we are today, and that's a huge shift in numbers. And I guess what I want is just assurance that it's about necessity rather than capacity.
Yes, Councillor Kidger, is that a quick question?
It is a quick question. You spoke about an incident where you had somebody where they were being abused and somebody was going in somewhere and taking, I'm sorry, I'm addressing this to you, Shona, sorry. Yeah. Addressing, well, I've had a similar instance in Morley, and the housing was referring and nobody was taking it up. And it's gone to where the police have had to get involved. And also on another side of a dementia to do with my brother, we've found that through the police doing a referral, it's getting further down the line. But going back to this gentleman that's had to be moved and everything, the housing couldn't get anywhere. It was in a council property, couldn't get anywhere. And it's when the police have stepped in, so I'm not sure that, the work, the referrals are getting really through. It just seems that the police seem to do a better job, or not a better job, but have a bigger appeal to get something done.
It's really hard to comment on that individual situation without the knowledge, but if it's something that you would like me to look into, please let me have the name and circumstances, and I will. I think, as Councillor Gibson was mentioning, there is such a range of issues involved in being able to support an individual who is able to make a decision about their own future and the amount of risks that they're living in, that it can be very difficult to get the right response at the right time. So I'm not painting what we do in Leeds as perfect, but gave that example as an example of good practice that we would be able to. But if there's something that's outstanding, please let me know and I can look into it. Thank you.
On Councillor Hartbrook's question, I think we should step away and come back with some further assurance for you. And it could be, Councillor, that we can only give you half an answer because we're only going to be as good as the data. One hypothesis I'd be working with, and we'd have to put some figures against the percentages, is that we're not out of kilter with the national picture, broadly speaking, in Leeds. So, and practice does vary from authority to authority. Some authorities, for instance, take any concern through into a Section 42 process, which I think is ridiculous and not person-centered at all. But if you assume that actually we are reaching more people and we're doing, as you've seen in the report, huge amounts of conversations with Asian elder groups, the Chinese community, lots of neighbourhood groups. If we're assuming that actually that's raising people's confidence, and as you say, that's positive to actually raise a concern, we could well be finding that as at the front door for adults and health, for Shona's service, that actually there's more coming in there that doesn't require a Section 42 response, but does require a bit of support or advice or a signpost. And I think all I can do is, that's the hypothesis I'm working with. But I think you're asking, and as did Dr. Beale, a question about, well, just give us a little bit more of a narrative around the stats, because you want some assurance. And I think we should be able to do that. I should be able to do that as your independent chair. So it's something I need to take away, I think.
Yeah, I guess the equivalent for me, and not to put words in Dr. Beale's mouth here, is, if you were to say that, 30%, there are 30% fewer children in Leeds getting fillings on the NHS, you wouldn't class that as a success. So it's understanding and I made that statistic up before anybody quotes me on it, but it's understanding the detail behind it.
Yes, absolutely. I think it's also understanding that, and I'm not saying you don't, that actually we want to encourage people to raise issues and concerns. What we don't think that will do is necessarily trigger a commensurate rise in the number of safeguarding referrals. It shouldn't, absolutely. But what I hear, Chair, is that we need probably just a little bit more digging, and we'll do that and come back to you through Angela with some further information and assurance.
Thank you very much, Richard. Yeah, we will remind you just in case you forget to come back. So yes, we look forward to that assurance. That would really help the board. Dr. Bill, you happy with that? Excellent. We'll bring that agenda to a wrap and say a huge thank you to Richard, Fiona, as well as Shona for your contributions to that agenda. Thank you very much. Feel free to stay. We're such a lovely board that we enjoyed the entire agenda, but if you've got to go, by all means, thank you very much for coming. Okay, really sorry for those for the second agenda item number 8, those who have been waiting. We're ready now, and that's on the review of out-of-hours bereavement arrangements at our Leeds Teaching Hospital Trust. So this is an agenda item that's also very close to my heart. So we're really, really keen to hear from yourselves this afternoon. So we'll give you a minute to get settled in whilst Richard and his team would be leaving us. So thank you. To all our guests, you're welcome. We've got teas and coffees as well, and some fruits if you would like some. So please feel free to help yourself. I can give you 2 minutes for that. But if you're okay, then we will start. Okay, so you're all very welcome. Agenda item number 8 on review of our out-of-hours bereavement arrangements at Leeds Teaching Hospitals. In September 2019, this board received a briefing from Leeds Teaching Hospital Trust regarding changes to its out-of-hours bereavement arrangements aimed at improving the experience of bereaved families. Such changes involve the introduction of new processes to enable the timely release of deceased adult patients for ceremonial and burial purposes for religious and, of course, cultural reasons. However, The Trust is now undertaking a further review of its out-of-hours bereavement arrangement, and we have invited you in today to engage with the Scrutiny Board at this early stage of the review process. So it will be nice if you could kindly introduce yourself if you have just joined us. So I will start with Rob.
Hi everyone, I'm Rob Newton. I'm Associate Director of Policy and Partnerships at Leeds Teaching Hospitals.
Good afternoon, Chair. Good afternoon, Councillors. My name's John Adams. I'm the Medical Director for Governance and Risk at Leeds Teaching Hospitals.
Good afternoon, Councillors. My name's Rhys Wolfenden and I'm the Lead Service Manager for Bereavement and Medical Examiner Services.
Good afternoon, I'm Mike Philpott. I'm General Manager for Pathology Services that covers the mortuary at LTHD.
Good afternoon, Chair. Good afternoon, Councillors. My name's Ben Rhodes. I'm Head of Chaplaincy Services. We provide spiritual, pastoral and religious care to patients, staff and their relatives.
Excellent. You're all very welcome. I believe there's a presentation to be made. And could I kindly ask board members to just hold on until the presentation is complete, and then we can now come in if that's all right. So over to you, sir.
Thanks very much, Chair. And just to introduce myself again, I'm Dr. John Adams. I'm the Medical Director for Governance and Risk at Leeds Teaching Hospitals. I came to Leeds as a fresh-faced teenager in 1987 to study medicine. I trained here and I've been a consultant here for 20 years. So like my colleagues, I'm well invested in the hospital, well invested in the city, and we're very keen to ensure that we deliver for the community what they need in this respect. I'd like to thank you for the opportunity for allowing us to come and speak to you today. It's first of all, it's fantastic to have sort of be able to meet you face to face. It's been a long time for us, and we're only just getting back to the face-to-face meetings, and in such a wonderful environment as well. So I'm very grateful for the opportunity, and hopefully this will be the first of a series of engagement pieces where we can have constructive dialogue about how we move this process forward. But first of all, I thought it'd be helpful just to give you a bit of background about where we are at the moment with out-of-hours body releases. So if we could just move on to the next slide, please. You will see, as you've sort of quite rightly pointed out, Chair, that in around 2018-19, we refined our processes with regards to the release of bodies out of hours from the Trust. And as you quite rightly mentioned, that's essentially for cultural or faith reasons. And of course, in some sad circumstances, children are also released out of hours as well. Now, what happens when a body is released out of hours? That's essentially a process that we need to follow to ensure, obviously, that the correct procedures take place. And that's facilitated by a clinical site manager. It's probably helpful for me to explain what a clinical site manager is so that we're all absolutely clear. The clinical site manager is a senior nurse that works on either side of the city. There's one at St James's and one at the LGI. And essentially, they are the troubleshooter for all manner of issues that occur in the Trust out of hours. It might be that a staff member calls in sick and they have to move around staff. It might be that we have a violent patient. They oversee all of the transfers and all of the patient flow out of our emergency departments. If there's a leak, if the lights go off, this is the person that essentially deals with this. And the site manager also has the responsibility for releasing the bodies from the mortuary as well, make sure that due process is followed. Next slide, please. So if we look at our current provision, we do facilitate body releases from our mortuary on both sides of the city on a 24-hour basis. And in the weekdays, Monday to Friday, which is sort of 9 till 4:30, 5 p.m, that's facilitated by our mortuary staff. But in the evenings and weekends, it's our clinical site managers who provide that service. And up until sort of, I'd say probably the last year or so, that has worked pretty well. The difficulty we now have, councillors, is the fact that the clinical site manager is often not in a position because of other operational pressures to try and facilitate that body release. And that can lead to sort of difficult situations where they're trying very hard to juggle a number of balls at the same time. and be able to release the body in a timely fashion whilst dealing with other urgent clinical matters that are going on in the trust at the time. If we now move on to our next slide, please, and have a look at our preferred options of what we're going to do from now on. We're essentially looking at the best way that we can manage our service and meet the needs of our community with regards to release of bodies out of hours. What we are hoping to do is develop a model, which I'll come to in future slides, but essentially we're going to have what we'd like is an 8 a.m. to 8 p.m. service on weekdays and weekends. So essentially, there would be a service that would start from 4:30 till 8 p.m. in the evening, which the site managers would facilitate, and similarly an arrangement between 8 a.m. and 8 p.m. on Saturdays and Sundays as well. And my colleagues will be able to sort of give more detail about that if necessary, and about how that would work. If we just move on to the next slide, if that's possible. So these are some of the considerations, and I won't go through them in any great detail. They're there for you to read and digest. But what we are hoping to do in this process moving forward is establish clear policies and practice for out-of-hours body releases for both weekdays and the weekends. We're very keen to try and meet the needs of our faith communities in this respect, and to make sure that we release bodies in a timely fashion. One thing that we do have to bear in mind is the role of the medical examiner and the impact that will have when statutory changes come into force in the beginning of April. And for those of you not familiar, it's probably worth me just sort of saying something about the medical examiner before we move on. Essentially, the medical examiner now is a statutory requirement where all deaths that aren't referred to the coroner are reviewed by a medical examiner. And the trust, like every other hospital in the country, has been working towards meeting that statutory requirement. And essentially, the medical examiner is the conduit. He or she is an independent person working within the organisation, who's the conduit between the family, the registrar, the funeral directors, the coroner, and of course the hospital staff. And the medical examiner has the responsibility for scrutinising the patient's death and giving the family an opportunity to highlight any concerns possibly about care, or to give advice to the medical team as to whether a referral to a coroner is required. Now, our current understanding is that from April the 1st, the medical examiner will be required to scrutinise all deaths that aren't referred to the coroner. And of course, the medical examiner will work the same hours as the registrars within Leeds. And so there could become an issue whereby you'll be waiting for bodies to be released until they've been reviewed by the medical examiner. So Rhys may well be able to speak further of that in due course, but that's where we are with that particular issue. And of course, that's something that's outside our control. Moving forward, we want to have a system that is fit for purpose, that meets the needs of our community, but also balances the very significant pressures that the trust is under at the moment. And I can't understate the difficulties we have with numbers of patients coming to hospital, the difficulties with discharging patients to suitable social care or facilities or back at home. The site is under enormous pressures at the moment, which look to be sustained and will continue into the foreseeable future. So what we're hoping to do is have an engagement process and come up with a suitable plan that meets the needs of everybody. If we could just have a look at the timeline. Apologies if it may be difficult to read on the screen, but if we look at the next slide, you'll see essentially that the timeframes are fairly short here. We're fairly ambitious in what we're trying to do. By the end of March, we are hoping to have a new model identified. By the 1st of April, we said already that the medical examiner will be required to scrutinise all non-coronial deaths. In April, we'll be hoping to test the new system and implement it at the beginning of May. We'll then be looking for feedback from interested parties about whether it's working for staff within the hospital and our colleagues and communities within the wider Leeds area. So just a final slide is on our engagement piece. These are the groups that we think we will need to speak to. We welcome your comments and thoughts about this, and any comments that you may have about how we move this process forward. That's all I wanted to say, but maybe an opportunity for some of my colleagues to come in before we have any further questions. Thank you.
Thank you very much, John, and thank you for putting our board as the first engagement team on your list. So we appreciate that. Any of your colleagues would like to say anything before we open up to board members? You all happy with what John has said to us? Fabulous. Right, board members, over to you. Who's going first? Yeah, Councillor Farley.
Okay. Thank you for the presentation. I suppose I think my first question would be kind of what are the blockers in terms of release? Now, I appreciate obviously the CSM is overseeing, the two huge hospital sites in Leeds. I would assume that the CSM doesn't have powers of delegation to just sort of let somebody else deal with the release of bodies. Is that correct?
Yeah, that is correct, actually. One of the principal issues that we have is making sure that due process is followed, ensuring that the right bodies are released from the mortuary with the correct paperwork. So it's vital that we have someone who's trained to do that. And one of the opportunities that we have now is to see whether there are any other suitable people who could facilitate this type of duty. Have to say that sort of during early discussions, it hasn't been straightforward to identify a different group to do that, but it's something that we are considering.
Thank you. So with the position of clinical examiner overseeing kind of the process of release, is when we talk about looking at kind of how these roles can be expanded and delegated, that's not going to be just like a single individual, is it?
No, I think it would have to be a sort of a designated group, and that may be someone who is, for instance, in some trusts, it could be mortuary staff that are able to do that out of hours. Unfortunately, we don't have the manpower and provision within our mortuary to offer that at the moment. In some trusts, the chaplaincy can help facilitate a release, and in others, other people can be identified. So it's a bit of a mixed picture across WIAT, and I think it's also worth saying that we are collaborating with our WIAT partners to try and get a consensus on this and try and find a sort of way forward that we can all agree and sign up to.
Just for clarification, are there any particular clinical restrictions in terms of who can authorise the release? For obviously, as the NHS encounters greater pressures, we're seeing a lot more new ways of working. We're seeing a lot more people with different clinical skills taking on different roles. So, for example, I know just as an example, you might have a senior physiotherapist. Would they be clinically able to do that, or would that be outside of their remit?
I think I'll ask Mike to address that one.
Hi, Mike Philpott, General Manager for Pathology. The actual process of the physical release just needs to be somebody that is appropriately trained in following the process. The respective paperwork to be signed prior to that requires certain clinical input, such as the MCCD form and obviously the medical examiner process prior to it. But in terms of the actual physical release, it could be anybody that's appropriately trained.
So just to reiterate what you've just said, for someone to release, to give that certification, what they need is more administrative training, not any specific medical training for them to be able to release bodies. Is that correct? Just so that I understand what you've just told us.
Just the physical release part at the end of all the paperwork being signed is understanding the process of being able to administratively release and do all the form checks and so on. It's not a clinical process at the end of the process.
Okay, yes.
But in terms of who can physically authorise the release, that has to be a clinician that has been involved in the patient's care and seen the patient in life in the previous 28 days. So the release paperwork, the medical certificate of cause of death, has to be completed by a medical professional. They cannot complete that documentation until they've spoken to a senior consultant.
Okay, that's clear. Thank you very much. Councillor Iqbal and then Councillor Taylor.
Thank you, Chair. And can I welcome everybody to today's scrutiny board, and we're really grateful that you've attended with the full team so we can have a meaningful discussion how to move forward. Obviously, this was flagged up with the experience myself and Councillor Marshall Katong had, where there's been a few cases where somebody died unexpected natural death on a Friday evening, and we're told to wait till Monday because we don't have any staff and we can't release the body. I've been, as Leeds City Council's bereavement services representative, the champion now, the new title. I've been involved with most of the religious cases where the support has been varied between clinical site managers, some very helpful, some very much by the book, depends on circumstances, but it was flagged up because of the several cases in the last 3 months. Now, originally, when this service was introduced in Leeds, was after seeing other West Yorkshire Combined Authority teaching hospitals doing early releases, whereas Leeds were far behind in terms of meeting communities' needs on cultural and religious basis. And as a result of that, we had discussions in the scrutiny board, and this was agreed mutually with the support of a hospital. And we understand the immense pressures. However, this is a very sensitive issue. I don't think community wants the body at 2 o'clock in the morning. It doesn't make any sense. Although being a councillor for 23 years, I've seen initially in early days bodies picked up from the wards by the funeral directors. And as far as my understanding is, the medical practitioner, as Reece has mentioned, the MCCD certificate, which is signed the cause of death. And if the consultant is certain that the cause of death is clear from all the medical records and the patient's been in hospital for so long, then there's no reason for post-mortem, but the deceased can be released. And I think the suggestion of 8 to 8 is reasonable and sensible. We want to be practical on how to provide best service, but then the medical examiners coming in and finishing at 4 o'clock causes a big problem and not very helpful to the community's needs, obviously, for all the reasons. And faith communities, the coroner's service, we've got excellent service, excellent relationship with the coroner's service, who are available 24 hours, 7 days a week through the police, and some officers are so helpful, they've given their mobile numbers. The registrars are available 7 days a week. The cemetery service is available 7 days a week to meet the needs of the communities. And those members who wish to have this priority, there's no reason to meet their needs. So therefore, we've not done a wider consultation, but I can speak on behalf of the Muslim community, whom I work with a lot, and also the Jewish community. And I've got a statement to read from Simon Phillips, who's the chair of Jewish Board of Deputies. It says Interfaith Director for the Leeds Jewish Representative Council and Leeds Joint Chevra Kadisha, if I've got the pronunciation right, co-chair. The provision of out-of-hours bereavement services for the Muslim and Jewish community are critical in ensuring we can exercise our religious responsibilities to bury our dead without delay. This is particularly important on weekends when we know that cover may not be as widespread as during the week. We are aware of recent changes seem to have made matters more difficult. Respectfully, we are concerned about the impact of these changes on our ability to provide timely burials rights to members of our community and fully support any efforts made to improve the position. We would be happy to meet with relevant stakeholders to express our concerns in more detail or to provide any further information or assistance. So in the outset, I mean, first of all, you know, my question would be, are all the hospitals going to have the medical examiner, or is it just Leeds? Like other throughout the country, is it a national policy? Secondly, I mean, I understand the pressures on trusts, and 8 till 8, I think it fits in line with cemeteries, registrars, and the coroners, and it's practical because, you know, releasing body at 2 o'clock or early in the morning is, you know, we need to be a bit sympathetic towards the trust's approach as well. But then the issue comes of medical examiners finishing work at 4 o'clock or 5 o'clock. So we're back to square one, and we're going 10 steps backwards. And I'll leave it open for you to respond to this.
So yes, the medical examiner service will be applicable to all NHS organisations within England and Wales. The thing to be mindful of is that it includes all deaths, so that includes deaths within the community. So although we sit inside Leeds teaching hospitals, we sit independent to the trust. So you've got GP practices that only work office hours and don't provide an out of hours provision, and that would be the same for the medical examiner's service. So we're looking for the legislation to be handed out from the government of what the provision will look like, the resources that are available, the funding that's available. And until that provision has been passed through Parliament, we can't project what our service will look like, other than that we will work with the community to offer an out of hours service over the 7-day period. But I can't say that it will be operational between 0800 and 2000, but there will be an out of hours provision of some sort.
I agree with you with the GP's practices, because when they were given the contracts, they were not given, there's no provision for them to provide service on weekends. However, for your information, a lot of practices in Leeds have agreed to give out the doctors' telephone numbers to community leaders and religious organizations. And doctors do come out to issue MCCD on expected deaths, just to support the families in order to fulfill their requirements.
I think, first of all, I'd like to thank the councillor for his really helpful feedback, and also to hear the comments from the Jewish community as well. That's really useful, and I hope this will be starter of a really helpful engagement piece between our organisations. Personally, I'm very sorry for the poor experience of the families that you have helped and assisted. It's certainly not what we aspire to as an organisation, and we will strive to do better in that respect. I think it is really helpful that you've recognised the pressures which the organisation is under at the moment, and hopefully we can come to an arrangement that benefits all parties, and we can see a clear way forward. I think Reece is right. I think the introduction of the medical examiner sort of statutory component from the 1st of April is a potential concern. And we'll have to see what the government says that was going to look like. But obviously, we will try and work wherever we can to still meet the needs of our faith communities with respect to out of house body releases, regardless of what that legislation says.
Thank you very much. Councillor Taylor and then Dr. Beale.
Thank you, Chair, and thank you for coming. And first, thank you for all the work that you have done through the pandemic. Thank you. I was going to mention majority of what Councillor Iqbal mentioned, so it's no need for me because he already gave it. But my question is, what's gone wrong? Something has gone wrong. This started happening in 2019. But if you looked at the slides they put up earlier, the consideration, reading down is really down to funding that affect the NHS, given all these. We know the NHS have got pressures at every corners, with the doctors combined together. So after reading the consideration up there, the second paragraph down, I do know every member of staff have hours to work to 20, 30, 40, whatever. So is it the financial struggling in the NHS that put pressure on this, that why the culture needs cannot met with their disease? Is it because, I don't know, but is it something went wrong from 2019? And I'm glad you didn't say it was the pandemic, but really reading the sign, I think it's the finance one, the struggling with the staff already overworked, and obviously don't want to put no more pressure. I was just saying to my colleague, the coroners that would come out, they might have done their 30 hours, so it might be their discretion to come back out to do the certificates. Am I right? So it's the way it is going. And the final question is it across the country this is happening? And you have no reason to be apologized for, to say sorry, because if it is the struggle because of the government, you are, alongside many others, are doing the best you can to provide. But my heart goes out for culture, because before 2019, as an ex-NHS staff, we never had this issue. So it's all down to pressure on the NHS, why culture are deprived of their services.
Thank you, Councillor. I think you make some very valid points there. And of course, COVID did come along, and that was a very significant challenge for us. And its legacy, unfortunately, has left us in a very difficult position with respect to both, I guess, workforce and funding. It is certainly true to say that we have very significant workforce challenges. Like every public sector organisation within the country, we're no different from anybody else. Staff retention is always a challenge, and of course funding is always an issue, and it may well be that part of the solution is that we will have to find dedicated funding to make sure that this out-of-hours service is properly manned. So yes, those are both important considerations. Rhys may be able to speak more widely about the national picture, but it's certainly the case, having spoken to colleagues across West Yorkshire, that they are all feeling the same sort of pressures, both operationally and also release of body out of hours as well.
Okay, thank you, John. Dr. Bill, and then Councillor Arif.
Thank you, Chair.
Does Rhys want to respond?
Yeah, just to say sorry, that although funding and staffing is one of the main issues, we have to be mindful that we can't predict what happens clinically. So although a patient has passed away and require imminent release, if there is pressures on the ward due to a medical emergency or whatever reason stops the clinician from certifying that death, it's all a block to the release of a patient. So it's not entirely principle of funding and staffing, it's what is going on clinically across the hospital.
Thank you, Chair. My question has partly been addressed, but I'd like to pursue it a bit more. It seems to me that there really are two issues. Pre-COVID, back in whenever it was, you said 2018, changes were made, which were, I think, probably a substantial improvement to the situation which was there before. Okay, it may not be perfect, and we've heard that improvements need to be made, and the trust could do that. But now we hear about these medical examiners, which apparently is going to be in legislation. Now, we are now 3 quarters through February, and we've got March. So we've got 5 weeks, and we still don't know what the legislation is going to be. I don't know, but maybe someone does know, whether it's going to need primary legislation. Parliament will have to actually consider it, both houses, or whether it will be done in secondary legislation by a statutory instrument, which is quite possible. But even so, I would have thought that the government needs to be aware of the problems which will arise from their intending legislation. And I think, everyone sitting around this table, whether a councillor or not, has a member of parliament. We ought to be making sure that our members of parliament are aware of the issues, particularly for a city like this, a very diverse population, a large number of people of Muslim faith, of Jewish faith, and so on. And MPs should be aware of the issues which need to be faced. And we should not let the government just pass through willy-nilly legislations, which is going to have a profound impact on the population of cities like this, and indeed nationally. So it's really just, does anyone know how the legislation is going to be undertaken, and what can we do about it?
I think the short answer to that, unfortunately, is that we are none the wiser, and we would very much like it to be clarified as soon as possible. I think realistically the timeframes will get pushed back. I think the government will have to realise about the potential impacts of this legislation. So I think it is inevitable that the timeframes are just too short. But we would like some clarification as soon as possible.
And just to add to that, the government are acutely aware of the issues that are faced out in the community, and part of the provision of the medical examiner service will be the digitalisation of the medical certificate of cause of death. So that is very much a paper-based process at the moment, but we're looking at a digitalised solution going forward, which will make the MCCD more available to practitioners out in the community and out of hours. So there is a bigger picture which is being assessed.
Okay, thank you, Councillor Arif, and then Councillor Arif, then Councillor Burke, then Councillor Farley.
Thank you, Chair. I welcome this conversation. I do think there's a problem in the service, and that to me is evidenced by the number of phone calls I get on a weekend sometimes, and that has really gone up in the last few months. I represent Gibson Hare Hills. There's a large Muslim population there, and there's almost a lot of panic at that time from residents say we're just not being able to get in touch and get the body released. I have a question in terms of the clinical site managers. Are we looking to increase the capacity of the clinical site managers? Obviously, they have other things and other duties to do, and sometimes that will be priority for them. So as part of this review, is that something you're looking into? In terms of engagement, I think that's really important that you're looking to do with the board, with faith organisations and with the funeral directors. But also just as an elected member, sometimes I just feel the process for me is a little bit complicated. Who do I reach out to? And I think perhaps as part of this exercise, there's more we could do with elected members, just a bit of a guidance for them to pass on to their local residents as well, as and when the need arises. But I do think something needs to change, because I've, in my 6 years as an elected member, have never known the service to be performing as it is, unfortunately, and totally acknowledge the pressures that you're all facing. And I think hopefully this exercise will help with mitigating some of those issues that are happening. Thank you.
I think their comments very well made, and I'm very sorry for the experience of your community members who have suffered in this way. I think you have highlighted, unfortunately, the very real, very sustained pressures that the trust is under, but also the importance of that dialogue going forwards to make sure that we can reach a solution that works for all parties. I don't think going forwards that the site managers will be the answer. I think it will have to be somebody else. I think their workload is just too great, and I think it will have to be a different solution.
Thank you very much, John. Just to add to what Councillor Arif has just said, the only reason we have called yourselves is because of the number of complaints we've received. So outside of being the chair for this board, I'm also the faith champion for the council. So you can imagine how many people tell me about this. And obviously, if we're not talking about the solution with the people that matter, then we will continue to be in the same problem we're having. So obviously, after listening to us today, I'm glad with all the list of people that you have put down to be able to seek their views on coming to a solution, of which your LTHT staff also are part of the solution. So obviously you will hear from us today, and if we need to come back with other groups to make sure we get to the right solutions for the community and for the city, obviously, because it's a very, very diversity, and we actually take huge pride in our inclusivity. So for us, anything that will enable yourselves and ourselves as elected members, that when people give us a ring and say, I'm struggling with this, we do not always have to make phone calls and press buttons for people to have bodies released, when it should just be done via the process. So some people know how to press buttons and some people don't. So those that do not know how to press buttons are there suffering in silence when they have lost somebody. So I'm just trying to reiterate the importance of why we have called you in today, and to say we have only called you in just because the complaints are more than 1, 2, 3, 4, 5. Councillor Burke and then Councillor Farley.
Thanks, Chair. Thanks. Quite interesting to listen to what you had to say. I've got a couple of questions. First one, obviously there's obviously always a capacity issue, isn't there? Let's be absolutely frank. And I was reading the reports that have been done in the pilot areas, and because the government's adopting that, it's quite obvious that what's happening in the pilot areas will be pushed through in one way or another. So my first question is, how many medical examiners have we got trained in Leeds? And if you can't answer that, perhaps Yorkshire, I don't know how you divide it up, but I assume it's Leeds. And the system 1, and is it EMIS? I quite like how that's going to operate. So perhaps you could, for the board here, explain how practically that will operate. I know what I've read, but sometimes it's much better, isn't it, to hear, because that strikes me, if everybody is aware of how that will operate, it kind of answers the question that Councillor Marshall's just said about knowing where to go at that really crucial point in time, because if it's almost like fast tracking it through, isn't it? So rather than having a negative effect, if we're aware and we get GPs on board because they're crucial, then that perhaps. And my last question is, how involved was Leeds, yourselves, and I can't answer for the authority, but I'm sure somebody in here perhaps can, in the it's an amendment to the Coroners and Justice Act going back to 2009, so it's not new legislation, it's just an amendment. So I'm interested in how involved Leeds were in the amendments that are going to take place. Okay.
So currently in Leeds Teaching Hospitals, we have 13 medical examiners and we have 4 medical examiner officers. So they support the administrative function to the medical examiner. We are currently recruiting for an additional 10 medical examiners, which will support the community provision as well. And that, in a nutshell, is the full team at capacity with funding what is currently available from NHSE. In terms of System 1 and EMIS, I can't comment on how it will look and work in Leeds, but I can comment on that part of the medical examiner's role is that the medical record should be readily available for the medical examiner to perform scrutiny at any point, any hour of the day. So we are currently working with the GP practices to establish the provisions that allow us to access the GP records, but it's not as simple as going to System 1 or EMIS. We have to apply to the 99 GP practices to have permissions to access their records. So that's where we're at currently. So although there are certain measures and processes that we can adapt from System 1 and EMIS, I don't know at this moment in time what that will look like for Leeds, but we're at the process of negotiation.
Thank you. So my mental arithmetic, being what it is, it strikes me we only have 2 CMS at this moment in time, and now we're going to have 13 based within the trusts. So that's an increase of 11 bodies, and I assume that the CMS will still be in place during kind of office hours. So that says to me capacity must, law of averages, basic maths must hugely be increased. So perhaps that will, if with that increased capacity, I mean, it's huge, that should reduce some of the issues that are displaying themselves at the moment. And my last question, you'll be pleased to hear, is perhaps, and I'm kind of looking at Victoria, not on purpose, but I am, perhaps public health or like the chair of our board or some other people can support that communication with GP authorities, because it's vital that they get on board, isn't it? So people can get that information during out of hours. It's a suggestion. I'm sure somebody will reply. Thank you.
I just probably need to clarify some confusion. I think Councillor Burke was referring to the CSMs, which is our clinical site managers, but also our medical examiners. So we have 2 clinical site managers on call every night, one at St James's, one at the LGI. The medical examiners are the independent practitioners within the trust who are scrutinising the deaths. And as Reece mentioned, we have a number of those now, and we're recruiting up to, I think, a total of, I think, 20. Yeah, 23 in total. So that will essentially allow us to scrutinise those community deaths as well. So just to sort of clarify the difference between the two groups.
Thank you, Chair. It was just a, I suppose I was just thinking of like practical steps we can take following Dr. Bill's contribution and questions earlier with regards to clarity on what the legislation will look like. I mean, imagine my shock to discover that this hasn't really been thought out by the government. Could I suggest, if it's appropriate for perhaps this body or for perhaps the executive member, to write to the appropriate minister responsible for this, to seek clarity as to what the legislation will look like? Because what I'm detecting from our LTHT colleagues is that you guys have been told, hey, this is going to happen, but there's no actual detail as to what this will involve for you to put it into practice. Is that a fair assessment?
Absolutely, and there is a lot of guidance on the web about the National Statutory Medical Examiners, and it does have what the government has distributed to certain organisations, which I can share with you at a later date. But yeah, it is out there what the recommendation looks like, but it's putting it into practice. And each NHS organisation does it differently. There is no set guidance, so it varies across each organisation.
Thank you. I mean, that sounds like a recipe for a lot of different practice across the country, and dare I say, a postcode lottery in terms of the service that people receive depending on the trust. So, I mean, Chair, would that be an appropriate action for this board to take, or for perhaps the executive member to write to the appropriate minister and find out what's happening?
I can't see why not, but I believe Councillor Arif would like to come in. She's the exec member for that portfolio. Thanks.
Yeah, absolutely happy to write and send a copy of that to the board as well, if that helps. Yeah.
Thank you very much. That'll be very helpful. So what you all are saying, you're happy for us to help you do what you ought to do. Is that right? Excellent.
Absolutely.
Okay. Councillor Iqbal.
Thank you, Chair. I just feel that, no fault of yours, but this is bureaucracy introduced, which no doubt release pressure on your department and staff, which helps the trust, but doesn't help the community, to be quite frank. And then the worry is, are these medical examiners going to be working 9 to 5 and 9 to 4 Monday to Friday, or weekends as well? So are we going to lose the weekend service under the national legislation, which is not going to be helpful to the faith communities and the service that we have been providing in the past, and it's going to be withdrawn because of the legislation?
So although not confirmed, the current provision is that the medical examiner sits between the hours of 0800 and 1600 Monday to Friday. When it comes to the weekend, we're going to hopefully coincide with the opening hours of registration services, so that if a body is required to be repatriated overseas, that the provision is there to allow that to happen without delay. So we don't foresee that the medical examiner's service will run entirely the full day of Saturday and Sunday, but there will be a provision to coincide with registration services of Leeds to provide that out of hours service. So without registration services, we can't give the green burial certificate. So it's important that we work alongside them to support both services.
But the green burial forms, there's community volunteers who have the green burial forms and they're able to issue them on weekends just by a phone call by faith communities. They have the registers. So I just feel that, you know, when there's a will, and with greatest deal of respect and pressures on the trust, when there's a will, there's a way, and the approach varies with person to person. And under this legislation, communities are going to face a lot of problems.
So I completely take on board what you've just raised there. But one of the issues that I have to highlight for members of the board is that although death is not scrutinised and there are community registrars that are able to issue a green burial order, the problems that I encounter on the Monday because a green burial certificate has been issued without casting an eye over the proposed cause of death on the medical certificate of cause of death creates me problems on the Monday with the body already interred over the weekend. And that many times when I come in on a Monday, I have to refer the death to the coroner with the absence of a body. So the medical examiner service will come in to provide the assurance that the cause of death which has been documented is accurate and satisfied us and the clinical team that there isn't a need for coronial referral. So it will benefit the community, but we just need all parties to be involved and take it on board.
The bodies are not released without the MCCD and, you know, certification and approval of the coroner. That's when the MCCD is issued and emailed to the volunteer deputy registrars or the register service. So why should there be an issue when it's a natural expected death and the cause of death is certain? The doctors, the consultant have given an MCCD, and what's the issue then?
So when you look at a cause of death on a medical certificate of cause of death and the way it's written can look entirely acceptable and that there's nothing untoward that makes that death unnatural. But when you scrutinise the medical records, for instance, there could be somebody that's had a procedure in the previous 12 months, a procedure in the last 2 weeks. And although it's not documented on the fatal sequence of the MCCD, it triggers a coroner's referral. So when you look at it on face value, it's an acceptable cause of death, but the underlying issues which led to that death deem the death unnatural.
So that's more of a procedural question, isn't it, in terms of medical? Yeah. Can the doctor, you're a doctor in pathology? No. All right.
No, I'm not medical.
Oh, you're a manager.
Yes, I'm.
So with your experience, can you help us with that question?
I'm afraid that process tends to happen outside of the mortuary. So that's more the bereavement side of things that Reece is describing. So.
Just for clarity, and I don't want to take up Scrutiny's too much time backwards and forwards. The usual practice is that if a doctor or consultant or even a GP is not very sure the cause of death is on the borderline, they often speak with the coroner, and in liaison with the coroner and all the medical records, that's when the doctor consultant issues MCCD. So that's the doctor's responsibility, and they do that. So the guy who issues the green form burial notice, it's not his responsibility to write down what the cause of death is. So I don't know what the issue is.
So the purpose of the medical examiner's service is to scrutinise the deaths which are not referred to the coroner. So if a death is deemed unnatural and requires coronial referral, there is a element of scrutiny which people who have a death that is natural don't have that element of scrutiny to provide assurance to the general public that the hospital did everything which is practically possible in the best interest of that deceased patient. So we're providing that same level of scrutiny to patients with a natural death, which are, for instance, being buried. So cremation, there is a level of scrutiny because the cremation papers are scrutinised by an independent medical referee. The deceased that are being buried do not have that same level of scrutiny. So it's providing an assurance of scrutiny across the board, despite how you die.
Okay, thank you, Rhys. Councillor Farley.
Thank you, Chair. I suppose that, I mean, this is a bit of a kind of you don't know what you don't know question. But do we anticipate, or what would you anticipate might be some of the issues that arise from this new system? I appreciate, obviously, it's not necessarily as in legislation, but what would you anticipate might be some of the issues that arise from this new system of medical examiners and whatnot? Thank you.
So the time the patient passes away, the complexities of family dynamics, the availability of the next of kin, because part of the process there is a requirement to speak to the attending practitioner who's looked after the patient in life. There's a requirement to speak to the next of kin. And there's also the issue of what their wishes were and determining what the exact wish of the deceased was. So yeah, there's many challenges which lie ahead, but it's important, like I've said previously, to work with the community to understand what the requirement is, and we will do that.
Thank you. I suppose what I'm getting at here is kind of, do we obviously we've seen among some of our communities kind of an increased amount of concern with regards to how long it's taking for bodies to be released in accordance with various religious practices. Can you foresee, and I don't want to, if you don't know, you don't know, but can you foresee with the new process an increase in these complications or delays, or do you hope that you'll be able to mitigate against that?
I can't comment currently without having the data, but yeah, we'll do what we can to avoid an increase in them, but yeah.
Do you have numbers, an average number? Obviously, you can't be exact, but average number of demands on Saturday and Sunday? I don't see too many, but perhaps you can enlighten me on what's the demand like?
I think if we could write to the chair and give numbers, I know that we've done some analysis. So I know that, for example, at St James's site, we have more demand for release at weekends, and at the infirmary, which is a major trauma centre, the demand for release of deceased people is in the evening. We also know that the majority, there were some children's moves. So one of the things about best care for parents who are bereaved is the coroner or appropriate authority will authorise a child to be moved to Martin House Hospice to have the best bereavement care. We know that the majority of people that are using the service are Muslim, with a significant number of Jewish persons. We also know that from our colleagues over in Mid-Yorks, the Romani and Gypsy traveller community, culturally, it's really, really important for them. So, but I think with the chair's permission, if we write the data there, but I think has been said, it's listening. I have my senior Muslim colleague and my senior Jewish colleague within chaplaincy are connected with the faith and belief organisations as well, and we're very aware and sort of, as the rest of my colleagues, listening to the community's experience and want to try and do our best for people.
Thank you very much, Reverend. I was actually keen to hear you speak. So now I know you're going to send me an email with some stats. So that will be great, because that will actually help the board in terms of the case that we're making with the challenges that we're facing, because I am very certain there are lots of cases that hasn't sipped through councillors that we don't know about. So I think the data will really show some clarity into the depth of the problem that we are currently facing. I believe, Victoria, would you like to come in here?
Thank you, Chair. And I'm mindful I've not met all my other colleagues previously. So hello, I'm Victoria Eaton. I'm the Director of Public Health for Leeds City Council. And just as a response to Councillor Burke's comment before, in terms of joining up some of these conversations about convening conversations with those in communities, I'm presuming in terms of the work with GPs, you're working with the GP Confederation, which represents all 99 rather than having to go separately to the 99. But obviously more than happy to support any of those conversations, and also mindful of the lots of ward members here are very involved in the local care partnerships, where obviously people around those local partnerships know the communities much more intensively than a citywide organisation. So we've got local primary care networks of GPs that come together locally. There's 19 of them for the city. And then we've got the local partnerships that include a broader range of partners, including ward members. So they may be on your list of people to go to talk to, and if not, we're more than happy to help facilitate some of those conversations. Thank you.
Thank you very much, Victoria. Councillor Harrington.
Thank you, Chair. Mine is a question about the recruitment and contracts. So we've said that we currently have 13 or 14 medical examiners, but you're looking to recruit another 10. Now, if the legislation is changing and the legislation states that you have to have these medical examiners in post to deliver the service that they're actually asking you to do, I totally understand that. Surely it's up to us when we're recruiting to say, okay, we can make a contract that says, actually, you are going to have to work some weekends here. So I know somebody raised a point over there, I think it might have been Councillor Iqbal, about the contracts that GPs had before, that it wasn't stated that they had to work weekends. But surely if we're actually recruiting people, we could say that at this stage and say, this is how we're going to do it. So we are going to manage it, that there will be a number of hours on a Saturday and Sunday that you will be required to work. Just a question. Thank you very much.
No, it's a point well made, and I would reassure the board that during the latest round of medical examiner interviews, first of all, we are specifically looking for GP colleagues to come and join us to help us scrutinise the community deaths. And we have been very clear, the expectation is there will be out of hours work at the weekend as well for the medical examiners.
Excellent. Thank you very much. Any other questions? Yes, Reese.
Sorry, I just wanted to highlight that the current medical examiners are consultants employed by LTHT, and their annual remuneration is made up of peers. And they're already tied into a contract that cannot be tweaked to facilitate out of hours and Saturday and Sunday working when the contract already stipulates what their contract is. So they work 4 hours per week per session as a medical examiner. It's not a full-time role. They're not directly recruited to just do that role. It's part and parcel of a full-time substantive post within the organisation.
Okay. Thank you very much. Any other comments, questions on this agenda item? Okay, first of all, we want to say thank you very much for coming and for coming in numbers with very short notice. We truly appreciate it. Could we ask, because we've got only one more meeting before the end of this municipal year, that you actually come back to us with some updates? What we could do as elected members within our remit, we would do regarding this agenda item, and we would also keep you in the loop. But I believe working together, ourselves and yourselves, should carry a lot more weight. And obviously, if we've got to write to the government regarding this, we will do. So we just want to say thank you very much, but we don't want you to leave just yet, because whilst you're leaving, that takes a lot of minutes. So just sit down and listen to the last agenda. It's not too long, and then we will be done, okay? Thank you very much. So I shall now call on Angela for agenda item number 9.
I'll try and be quick now. Thank you, Chair. Well, this is our usual report, relates to the board's forthcoming work schedule with the latest version set out in Appendix 1 for members' consideration. Just one area to note really, and that's the forthcoming working group meeting. So members will recall the board agreed to hold a working group to consider the current position surrounding the delivery of the Leeds mental health strategy, primarily with a view to identifying key areas where the board, where it would benefit from more focused scrutiny work to be taken forward into the new municipal year. So this has been arranged for 9th of March from 9:30 as a working group. It is an informal remote meeting and members should have already received the invitation. And it is the intention that a summary note of the working group's discussion will be shared with the full scrutiny board as part of its next formal meeting on the 21st of March. Thank you, Chair.
Thank you very much, Angela. I believe Councillor Farley, you've got something to say about the new LTHD director.
Thank you, Chair. I was going to suggest, given Leeds Teaching Hospitals has got a new chief executive, Professor Phil Wood, I was going to suggest, firstly, writing to him to welcome him to his new role. He's got some very, very big Julian-sized shoes to fit, so very best of luck to him. But I think, secondly, it would be, I feel, a good idea to invite him along to this body, just to outline what his vision for acute care in the city is as the main acute provider, being Leeds Teaching.
Thank you very much, Councillor Farley, and we will do. And finally, Rob, actually, I was going to say something about you, but you go first.
Well, I can comment on that because I'm just I've been sat down with Phil looking at his first 100 days, if you like, and on the list is to come to scrutiny board. And if you've not received a letter yet, there's one in the post, figuratively speaking, that will be making its way to you.
Thank you very much. I just want to use this opportunity to also say thank you. He's been our go-to person during when we have bereavement issues and, organizing, and even on weekends, Rob will answer his phone. So Rob, on behalf of the board, we just want to say thank you very much. I know the director is sat beside him there. So yeah, do give him a pat on the back because he's doing a very good job. And we need more people like Rob to help the board, especially when we have to intervene on behalf of our constituents. So thank you very much. One more item, Councillor Harrington.
Sorry, Chair. I sent a letter to the chair about an issue that we've had. Some residents have raised with me issues about cancer treatment referrals. So people who are concerned that they may well have cancer need to try to get to see a GP and then need the referral that's ongoing after that. And that is becoming problematic. So I'd really like to know if we could do a piece of work to find out what the referral rates are, what the blockages are, and how many people are actually waiting and how long it takes them to get to see a consultant. Thank you.
Okay, thank you very much. Is anyone on here that can, any one of them?
No,
okay.
I'd advise we get
That's fine. It's nothing to do with you. So you're all free to go now. Thank you all so much for coming. We really, really appreciate it. Have a lovely evening. Thank you.